Our speaker is Professor Hsin-Hong Kuo. Today he will talk MRI change. He will change in uterine myoma before and after HIFU. Okay, let me introduce him a little bit. He is working now in Division of Gynecologic Endoscopy, Department of Obstetrics and Gynecology, Kaohsiung Memorial Hospital in Linkou, Taiwan. Actually, he is Deputy Secretary General for the APAGE and Deputy Secretary General in Taiwan Association for HIFU Therapy. He also is a Deputy Secretary General for Taiwan Association for Minimally Invasive Gynecology. His specialty is a HIFU advanced endoscopic surgery, breast, node, and robotic. He got award like a best video surgery technique demo using a K-box, a novel non-invasive training box that everyone can own, and best paper award from Taiwanese Journal of Obstetrics and Gynecology, best video alien egg laparoscopic adenomyosis, a novel method for APAGE Japan 2017. So I think it's my great pleasure to invite Dr. Hsin-Hong Kuo to talk. Please, Professor Dr. Hsin-Hong Kuo.
Hello, Sawadika. Thanks for the Professor Amphan's introduction. And I want to share my image. So I just proceed to share my image, okay? What's my today my topic is the MRI change, image change in myoma before and after HIFU. And I'm Hsin-Hong Kuo from Chongqing Memorial Hospital. So it's a typical story that before and after HIFU, we arrange MRI. Before, we can check the signal of the MRI, whether it's hyper-intense or hypo. So this case is a hypo-intense. We know that it's an easy case. Even it's multiple sites, but we just take less than 1 hour to finish this case. And after HIFU, we arrange MRI to check the non-perfusion area. So we can check the successful rate, the non-perfusion area from the preoperative T1 contrast and the post-operative T1 contrast. We just check the size shrinkage and we can know how success we have. But my topic is before and after the HIFU to have the MRI image. But I think before the MRI, before HIFU is far more important than the image after HIFU, because we arrange this MRI, we can prediction the outcome. And the most important part is we can have a precise diagnosis for uterine sarcoma. So today's my topic will focus on the diagnosis for sarcoma through the MRI image. So let's go back to the textbook. There are some classification of the uterine sarcoma. There are 3 origins of the mesenchymal tumor. The first one is the smooth, because I see my uterus, okay, because it's blocked by some window of the webinar. Okay, the first origin is the smooth muscle of the mesenchymal tumor. Another origin is the the sites below the endometrium, we call endometrial stroma tissue. So the third one is a mixed type. So there are some malignant format of the mesenchymal tumor. The malignant format of smooth muscle is leiomyosarcoma. And of the endometrial stroma tumor, the malignant format is ESS, or high-grade undifferentiated sarcoma. For the mixed type, there are MMNT, we also call carcinosarcoma or adenosarcoma. Today, my topic would focus on MMT and leiomyosarcoma because two of them are the most common uterine sarcoma. But I need to mention that currently, MMT belongs to endometrial cancer category because it's always origin from, it looks like endometrial cancer. But my topic is to use the MRI to detect uterine sarcoma. There are some special typical image I want to talk about the sarcoma. So I include MMT in my topic today. Okay, but the instance of uterine sarcoma is quite low. It's just around 1 to 2 per 100,000. But you know the prognosis is so poor. So the overall 5-year overall survival of carcinosarcoma or leiomyosarcoma are both of them are less than 70%. And even in stage 1 tumor, stage 1 cancer, the MMT is just 50%. And the stage 1, the 5-year-old overall survival rate is just around 80%. So we need to detect it before the surgery. Okay, my first topic is carcinosarcoma. It's the most common uterine sarcoma in all classification. It's around 50% of uterine sarcoma. The symptom of the MMT is just like endometrial adenocarcinoma. So the typical symptom is PMB and abdominal distension. Okay, so, but I need to mention that it currently belongs to endometrial cancer category. Today, I just talked about its image. Okay, so the image, typical image of the carcinosarcoma is so like endometrial cancer, and it's usually a big, bulky tumor, polypoid mass in endometrial cancer. And sometimes when we find it, it's usually fill all the cavity and often is prolapsed through the endocervical canal to the vagina. And from the MRI image, we can check the evidence of invasion. And in the T2 image, we always find the sarcoma is heterogenic. And in the T1, the most important is we use T1 contrast image and to have evidence of invasion. And the most important part is, remember, just arrange endometrial survey, have a resectoscope and have a biopsy, and you can find the carcinosarcoma. So for MMT, it's not hard to diagnose it before HIFU because we will arrange MRI, right? And it's a T2 image. T2 image, we can find the heterogenic mass. And it's a T1 contrast here. We find that there is some evidence of invasion. And there are part of the tumor have central necrosis, but it's fine. You don't need to be an expert to diagnose it. Oh, it's MMT. You don't need to do that because you find it's in the endometrial cavity. So just arrange an endometrial survey and take a biopsy, and you will detect this lesion. So I think MMT is maybe it's hard to diagnose it from the image, but easy to diagnose it from endometrial biopsy. So I think it's fine. But our enemy is definitely the leiomyosarcoma because it's the second most common uterine sarcoma, account for 40% of uterine sarcoma. And the symptom is hard to detect because the symptom just similar with benign uterine myoma. So the typical symptom is bleeding, pelvic mass, and the pain. The timing to have a leiomyosarcoma is usually in the early 50s of the woman. Also, we can check the image. The image is so variable, but typically we can detect the heterogenic mass in a T2 image. And in this T2 image, we will find central necrosis. And the most important is, if it's a typical image, it looks like the cloud blow in the wind. So we can check some image of leiomyosa and whether they have this typical image later. And in the T1 contrast image, just look like an MNT, we can solve that central necrosis and have some evidence of invasion. And there are some weighted image like DWI and ADC. We can have the image of high celerity in a in certain parts. Okay, so it's the first typical image. Left side is a T2 MRI, T2 weighted MRI. You can see the hyper intense lesion here just look like the cloud blowing in the wind, okay, in a weather map. So remember this typical image, and maybe next time you can diagnose this by yourself according to the MRI. And this transverse view is a similar, the cloud blowing in the wind. Okay, it's a T1. T1 non-contrast have not, some rich information for us, but for the T1 contrast image, we can solve the central necrosis. And in the lateral part is a tumor invasion to the normal tissue. And we can find hypercelularity evidence. From the DWI image, the hypercelularity means hyperindense. But for the ADC, it means hypoindense. So according to the information above, we can detect leiomyosarcoma. It's another case of leiomyosarcoma. Okay, we also saw the typical image. It's a cloud blow in the wind. And in the T1 contrast image, we can solve the central necrosis and some peripheral tissue with hypercellularity. Okay, the typical image we can detect, we can know it's leiomyosarcoma or uterine sarcoma because it's a late sarcoma. But in the process, they're forming the sarcoma in the early stage is really hard to detect. So we go back to a clinical pathway. So when there is a patient come to visit you, and you have a baseline ultrasound and you have this image, it's a big bucket tumor in the uterus, in the myometrium, and there are some evidence of central necrosis, and the image quite heterogeneous. Even it's just grayscale ultrasound, you will gut suspect, this could be a sarcoma. So you will arrange MRI, right? But the problem is, how about the early sarcoma? When in the beginning, the foreign sarcoma is really hard to detect. So in this timing, would you arrange MRI? I think it is the nightmare for every gynecologist if you want to do the HIFU and you really want to avoid of this condition. Okay, so I want to ask every audience, there are 6 pictures. Which one is a leiomyosarcoma? If you just have the grayscale ultrasound, and it's a test. So let's check it one by one, okay? Is bucket tumor heterogeneous central necrosis? Okay, this one, we also have these pictures, and this one is okay. I think everyone could suspect malignant transformation in the above 3 image, right? But how about the below 3 image? Okay, this one is, maybe there is some central necrosis here, but it is quite, well circumstanced tumor. Okay, it's a round tumor without central necrosis, and it's quite homogeneous. This one also. How about that? Which one is leiomyosarcoma? Okay, sorry. All of them are leiomyosarcoma. So I want to share a picture, a drawing picture that we have some idea to make diagnosis of leiomyosarcoma. In the process, the foreign leiomyosarcoma definitely is from a single cell and it's got a mutation and change to a cancer, right? But in this time, it's just share the same picture with benign uterine tumor. And gradually the tumor got grows very rapid, and the vessel can't feed the tumor. So there is some central necrosis and some debris here. So all of this feature comes to have this typical image of MRI, is a cloud blowing the wind. But our problem is we need to detect the unexpected uterine sarcoma. The uterine sarcoma in the early stage, and we can't diagnose it well. So the unexpected uterine sarcoma is our nightmare, and it's also a big news event in the 2014, right? Dr. Amy Reed do the hysterectomy, and the doctor used Paul macerator to macerate the unexpected leiomyosarcoma. So the macerator was banned by FDA in America. So how the instance of unexpected uterine sarcoma? Okay, so we know the instance of uterine sarcoma is about 1 in 100,000, right? But the rate of the instance of unexpected uterine sarcoma is quite high, 1 in about 300. Okay, so it's quite high. So that's why the FDA abandoned the uterine sarcoma. But is that true? Okay, so there is a annual congress in 2015. I attend that in Japan. It's a Japan Society of OBGYN Gynecology and the MIS. The official number to have the instance of an expected uterine sarcoma is lower than FDA published. It's 1 in around 1,500. It's 1/5 rate than the number published from FDA. Why? Because they say the Japanese doctor mentioned that there is a number before the surgery, any kind of surgery, even it's laparoscopy, laparotomy surgery, they usually arrange MRI before the surgery. For the hysterectomy, all of the patient before the surgery would arrange MRI. And before the myomectomy, it's around 99% patient have MRI before surgery. So you may have an idea that if you arrange more MRI and the radiologist read more image, and they have be more experts to diagnose uterine sarcoma. Okay, so it's a data published from our hospital, Chang'an Memorial Hospital. It's the chief of the radiologist, Professor Lin. And because we are a center in Taiwan, right? And we do a lot of MRI comparing to the local hospital and other center hospital in Taiwan. So our detection rate is quite high. And the most important is MRI have a very good NPV. NPV means that if the test say it's not cancer, it's really not cancer. So MRI is so important before any surgery and to detect leiomyosarcoma and rule the leiomyosarcoma or uterine sarcoma out. Okay, so we go back to this 6th picture. So our nightmare is the picture in the below 3, that because all of them are early sarcoma. So how to detect that? In my opinion, early sarcoma is firstly suspected by what? It's not by image, it's not by, because you won't arrange MRI in every case, right? So I think it's suspected by suspicious symptoms. Okay, so I need to announce that there are some typical suspicious symptoms we can recheck that. The first one, rapid tumor growth. my experience is if the tumor got double size within 3 to 6 months, we need to doubt it. I doubt it's leiomyosarcoma. Even if it's small, you can follow this case with close ultrasound follow-up, right? Or you just arrange MRI, persuade the patient to have self-paid MRI because I highly suspect it's MRI. You just explain that. So it's a first sign of suspicious symptom. The second one is because sometimes we arrange laparoscopic surgery, we arrange surgery and we have some premedication, right? The most common is GNRH agonist. The tumor gut growth even with GNRH agonist. That timing we need to suspect is leiomyosarcoma or uterine sarcoma. The third objective factor is tumor growth even after menopause. In my clinic, usually I check the FSH because, in the age of 50 to 55, it's hard to explain the bleeding because sometimes perimenopausal bleeding or sometimes it's postmenopausal bleeding. So usually I check FSH. If FSH is quite high and if a tumor gut grows, I would suspect it's leiomyosarcoma. And because I'm also a HIFU doctor, so another important thing is after HIFU, you need to recheck the image. You check the volume reduction rate, and also you need to check whether the tumor gut grows again. After HIFU, if you have very good non-perfusion area, but the tumor gut grows again, you need to suspect it's a leiomyosarcoma. Even it's after HIFU, but I think it's also very important a sign to that it's a suspicious symptom. In this timing, you need to arrange MRI, even if the ultrasound, grayscale ultrasound is still very like benign uterine tumor. Okay, so my clinic survey for HIFU and my the take-home image of this topic is that we need to check in the clinic. We need to arrange grayscale ultrasound and to check a blood draw to have some certain marker. But another important issue is you need to ask the symptom, the subjective from the patient, whether there is some suspicious symptom. If that, you need to arrange MRI because the MRI have very high NPV. You need to rule the sarcoma out. And because if the condition is that in your hospital, your radiologist can't read MRI very good, please consult another MRI specialist. And if there is some bucket tumor in the endometrial cavity, please arrange resectoscope and have some biopsy. And if you do HIFU, after the HIFU, please close follow up the image and to detect whether it's grow up even after HIFU. So thank you everyone. That's my talk. Thank you.